All right. Good evening, everyone. For those of you who don't know me, I'm Laurie Ledley. I am the founder and president of Valley Sleep Center and Valley Sleep Therapy here in Arizona. And tonight I am so excited to invite and welcome Dr. Sharon Gnagi from Phoenix Children's Hospital. She is an ear, nose, throat surgeon. She specializes in head and neck surgery. Let's see here. She treats all aspects of anything pediatric, ear, nose, throat. She has a special interest in head and neck tumors, congenital neck masses, the surgical treatment of obstructive sleep apnea, which we're all going to talk about. Hey, here's a fun fact, Dr. Gnagi. I'm a Burkitt's lymphoma survivor, almost 30 years. Yeah.
Congratulations. That's awesome.
Yeah, it's a very rare, aggressive lymphoma tumor that you might have diagnosed in your time. So we'll talk about that sometime. You have advanced training in the management of cleft lip and palate, and you really enjoy helping children better communicate by treating their speech disorders. So welcome. I'm so excited to have you.
Thank you so much for having me.
If you guys are on the webinar and you have questions while she's doing her presentation, please feel free to use the Q&A or the chat. And after Dr. Gnagi is done, we'll go over those. If you're on Facebook Live, welcome, and feel free to interact on there as well, and I'll get your questions answered. So thank you so much. You can share your screen now.
Awesome. Okay, let me do this.
Oh, and I forgot to tell you, I'm giving away a free sleep study, so don't leave if you have to be present to win. So somebody in our audience is going to get a free sleep study. So while you're presenting, I'm going to draw a name.
Awesome. All right, can you guys see this okay?
Yes, it's perfect. It's in the perfect screen mode. Good job.
Perfect.
I'll be here
okay.
Bye.
Well, thanks again for having me, and thank you for allowing me the opportunity to talk about something that I'm super passionate about and a patient population that I really, really love taking care of. So today we're going to be talking about the treatment of obstructive sleep apnea in Down syndrome patients. And we'll go into a little bit of detail in an up and coming treatment of the Inspire implantation. So I do want to disclose the hypoglossal nerve stimulator is not currently FDA approved for the age under 18, but we are doing it off label. And we'll also kind of briefly touch on some off-label use of some medications, including Flonase or fluticasone and montelukast, also known as Stimulator. So what is obstructive sleep apnea? It's a sleep-related breathing disorder that involves a decrease or a complete halt in airflow despite an ongoing effort to breathe. So hypopneas are those shallow breaths, whereas apneas are a complete cessation of airflow. You can have obstructive, where you're really trying to take a breath, and then central apneas, where our brain isn't telling our lungs take a breath. So obstructive sleep apnea in the Down syndrome population is extremely common. Up to 80% of children will have obstructive sleep apnea, and half of those will have severe disease. It's common for multiple reasons, including low muscle tone and several anatomic contributions, including midfacial hypoplasia, or the bony anatomy of the midface, relative macroglossia, or a large tongue. Many times patients or people think that children with Down syndrome have a large tongue, but it's really that they actually have a normal sized tongue and a small oral cavity. Typically have large tonsils, adenoids, and lingual tonsils, which is tonsil tissue at the back of the tongue, in addition to a propensity for obesity. So sleep symptom screening should be occurring at every visit for children with Down syndrome. Things that may also contribute to sleep issues for children with Down syndrome include hypothyroidism. So it's important to check our TSH. In addition, children with Down syndrome have been shown to have significantly lower dietary intake of iron than their peers. So checking for iron deficiency, which can also contribute to sleep issues in children, is important. And of note, there's a poor correlation between parent report and sleep study results in this patient population. Therefore, because of the high prevalence of sleep apnea in children with Down syndrome, we recommend a screening sleep study for all children with Down syndrome, no matter if they have symptoms or not, by age 4. And that actually is a recommendation put forth by the American Academy of Pediatrics. And then we also want to discuss weight, nutrition, and physical activity, as obesity is a significant contributor to obstructive sleep apnea in all populations, but especially this population. And for the diagnostic workup, the sleep study is the gold standard. And typically, we actually will also repeat a sleep study after a tonsillectomy, as frequently children with Down syndrome will continue to have sleep apnea even after our first line surgery, which is removing the tonsils and the adenoids. Other things that we do to look at residual obstructive sleep apnea may include what's called a cine MRI, which is an MRI movie, basically, where we look to see areas of obstruction in a child's airway, or a DICE, or drug-induced sleep endoscopy, where we induce a sleep-like state with anesthesia, put a small camera in the nose, and look for areas of obstruction that we may be able to surgically treat. So why is obstructive sleep apnea so important to treat in this patient population? This could have implications in high blood pressure, glucose intolerance, abnormal cholesterol levels, liver dysfunction, anxiety or moodiness, bedwetting, symptoms of ADHD or neurocognitive deficits. So issues with concentration, attention, energy. In previous studies have shown that in the Down syndrome population, that untreated sleep apnea has even had a result with less verbal IQ scores than children with adequately treated obstructive sleep apnea. Treatment options include ENT surgery, CPAP or continuous positive airway pressure, weight loss, bariatric surgery. While extreme, it has actually been performed for treating obesity in the Down syndrome population with resultant improvement in sleep apnea. Sleep hygiene, close clinical observation, oral appliances or palatal expansion, medications, which may include Flonase, which is a nasal spray, and Singulair, which is an allergy and asthma medicine that has been also shown to be helpful in the treatment of mild sleep apnea, and hypoglossal nerve stimulation. We're going to focus on the hypoglossal nerve stimulation a little bit later in this talk, but there are several surgical options. Our first line treatment is tonsillectomy and adenoidectomy. Beyond that, several patients in the Down syndrome population will go on to receive further surgical intervention for residual obstructive sleep apnea. Those surgeries may include a revision adenoidectomy, which can occur quite commonly in children with obstructive sleep apnea, a completion tonsillectomy if they previously only had a partial tonsillectomy, expansion pharyngoplasty, where we pull out the side walls of the pharynx or back of the throat, palatal surgery, nasal surgery, tongue or tongue-based procedures, which are quite common in the Down syndrome population due to a large tongue base or lingual tonsils, supraglottoplasty, which removes tissue just above the voice box that might be redundant or floppy, and then the hypoglossal nerve stimulator. So again, today I'm going to be talking about this up and coming procedure, but at the end of the talk, I'm happy to discuss any questions that you may have regarding other surgical interventions. So the hypoglossal nerve stimulator, what is it? It's an implanted device that was originally FDA approved in 2014. That's a treatment for obstructive sleep apnea. Many children with Down syndrome will have residual sleep apnea, like we discussed, and many patients are not able to tolerate CPAP or a mask on their face. In fact, many adults do not tolerate CPAP, and so many children will not as well. So we consider offering this surgical procedure when patients continue to have severe obstructive sleep apnea after tonsil and adenoid removal. They're not able to tolerate CPAP. There are not any other surgical procedures that would benefit them. And a sleep endoscopy demonstrates that they would be a good candidate. So who is a candidate? Currently, like I said, it's currently FDA approved for children for patients over the age of 18 with moderate to severe obstructive sleep apnea and no complete concentric collapse on sleep endoscopy with a BMI less than 32. Currently, it is being investigated for children and adolescents with Down syndrome aged 10 to 21 with a history of a prior tonsillectomy and adenoidectomy, again with a BMI less than 32 or less than the 95th percentile, severe obstructive sleep apnea with an AHI, which is how we measure the severity of sleep apnea, greater than 10 and less than 50, with less than 25% of those events being central. Not able to tolerate CPAP, ability to communicate discomfort, and again, no complete concentric collapse on drug-induced sleep endoscopy, which we'll talk about a little bit more. Who is not a candidate for this procedure? When general anesthesia is contraindicated, the patient is medically unstable, other medical conditions which may require future MRIs. The device is MRI conditional, but it's not yet FDA approved for chest MRI. Other implanted devices which could interact, bleeding or clotting disorders, those on blood thinners, taking muscle relaxants, or again, not a candidate on their sleep endoscopy. So the first thing that we do is we want to make sure that the patient will qualify with a sleep endoscopy. Because the hypoglossal nerve stimulator acts to activate the tongue and push out the tongue with respirations, what we want to see is that the patient primarily collapses during sleep front to back, because we know that by sticking out the tongue, it will alleviate that collapse. When we see a lot of side to side collapse, no matter how much we stick out the tongue, that patient may not greatly benefit from having their tongue sticking out if they're collapsing from side to side. And that's why those patients are typically not as good of a candidate for this particular procedure. The second step is implantation, where a sensing electrode is placed on the chest wall and senses our respirations. There's a second incision on the neck for a stimulation lead that's placed around the nerve that innervates our tongue. And with respiration, it's essentially a breathing pacemaker that syncs the tongue sticking out with our respiration to alleviate upper airway obstruction. This is an example of a surgery where we actually locate the tongue nerve, the hypoglossal nerve, and we isolate the branches that control sticking out the tongue and incorporate those branches of the nerve. Potential risks are bleeding, infection, or extrusion of the implant, pneumothorax, which is air collection around the lung, since we're implanting it between the muscles between the ribs, pain, swelling, or temporary tongue weakness, and some discomfort with stimulation. Rarely tongue paresis or atrophy, which I have not seen. After the procedure is done, we typically follow up and make sure that everything is healing well. And we activate the device approximately 1 month after surgery. And then 3 months after surgery, we have a repeat sleep study to titrate the device to get maximum benefit from getting the amount of stimulation necessary to get maximum effect. So as you can see here, this is a patient on a sleep endoscopy that had obstruction of the back of the tongue and at the palate. And with the Inspire device implanted, you can see that the tongue is pushed forward and it opens up the airway to be able to breathe easier at night. So moving on to some of the research that's been done in this area for adolescents and children with Down syndrome, I find really exciting. I really feel like this is the future. They did implants in 20 children, which are non-obese adolescents with severe obstructive sleep apnea. And what they found is that it was safe and effective. They had 2 minor surgical complications, which were corrected surgically. There was an average reduction in the AHI of 85%, which is great. And patients used it. So the average nightly usage was 9.21 hours per night, which is awesome, since most children will not tolerate this length of time with CPAP. And they had significant improvement in quality of life scores on a questionnaire that was performed by the parents. So the average age was 15 with a baseline AHI of 24. They had several patients that had a normal AHI after or mild AHI. Almost all of the patients had had improvement to essentially not severe obstructive sleep apnea. So 70% of the patients were corrected to mild sleep apnea. And again, on their quality of life survey, which looked at areas of sleep disturbance, physical suffering, emotional distress, daytime problems, or caregiver concerns, there was a significant improvement in all of these parameters. This is the area that I find the most exciting. As I mentioned earlier, prior research has demonstrated that children with residual obstructive sleep apnea and Down syndrome can have neurocognitive effects, with one study documenting a lower verbal IQ. They looked at neurocognitive domains in able to communicate via spoken language. They looked at intelligence, processing speed, expressive vocabulary, working memory, and parent reports assessing behavior, adaptive skills, and quality of life before and after Inspire implantation. And parents reported significant improvement, which is awesome. And so I find that to be really exciting moving forward for this implant, and really treating all children with Down syndrome and sleep apnea, and seeing how we can affect their quality of life and their family's quality of life. This is a patient that I was fortunate enough to be able to treat in conjunction with Valley Sleep Center that I'd like to share with you guys.
Ever since he was a baby, really. I can remember him snoring and having a hard time breathing, and as he got older, it just got worse. Even from the bedroom down the hallway, you could hear him. No one could sleep with him. We had a motorhome that we actually sold because he snored so loudly, it would keep everyone up. So for 15 years, he wore a breathing device at nighttime, a mask on his face, and still had severe sleep apnea. We had the good fortune of being referred to Valley Sleep Center a few years ago for a sleep study. And Dr. Martinez said, I think Danny would be a good candidate for Inspired. Something that everyone that's close to Danny has noticed is that he has more energy and he's more engaged during the day. He's even talking more without changing his diet whatsoever. He's lost 10 pounds, but there's an opportunity to make his life better and actually increase his health and lifespan. Why wouldn't you do it? Are you happy? Yeah, I'm happy too.
So I'm sorry.
Sleep apnea.
Just an example of how much improving patient sleep can improve their quality of life and their families. So I want to say thank you to our complex sleep clinic at Phoenix Children's Hospital, which I run in combination with Dr. Druick, who is our director and pulmonologist, as well as Dr. Krauster, and then my colleague within pediatric ENT, who also performs Inspire implants, Dr. Patrick Schaffler. Thanks to PCH for supporting this dream, Valley Sleep for helping us and putting this on with us today, and then the Inspire program and implant and their representatives, who are amazing to work with. And I'll take any questions at this time. I'll stop sharing.